I think it's time for us to move on to our panel. And I will be introducing the panel as a group, and then they will each be making some comments and asking a question of our speakers.
Yeah.
All of the panelists have had some either institutionally or personally involvement with the Rural Opioid Initiative. So there's a little bit of a theme here. I'll start with Dr. Holly Hagan, who is an epidemiologist and professor of global health at the School of Public Health at New York University. Holly has extensive experience at the intersection of substance use and infectious disease, primarily among people who inject drugs. And she also served as the ex officio chair, so she was an unofficial PI of the Rural Opioid Initiative. Next, I'd like to introduce Carolyn Wester, who is director of the Division of Viral Hepatitis at the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. Dr. Wester has had a variety of roles in public health, including academic medicine, and more recently with the Tennessee Department of Health and now with CDC. Next, I'd like to introduce Dr. Yngvild Olsen, who is the director of the Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration, better known as SAMHSA. Dr. Olsen is trained in internal medicine and addiction medicine, and her work has focused on opioid use disorder, as well as the integration of behavioral health and medicine and policy issues, as well as clinical issues related to overdose. And finally, I want to introduce Dr. Eyasu Teshale, who is a team lead and for the epidemiology research team at the Division of Viral Hepatitis, the same National Center at CDC as Dr. Wester. And his work includes working with ghosts in contexts other than our rural initiative. And so I think we want to turn it over to the panel, I think starting with Holly, although I see that John is on. We may have gotten, I think he may also want to provide some comments.
No, this is great. I want to just get right to Holly so we get have ample time for the panelists to comment and have a question. Thank you, Holly. Take it away.
Thank you. So first of all, thank you to the organizers for inviting me to be part of this webinar. And also I want to thank the speakers for their really excellent presentations. I'd like to focus my remarks and also my questions on people who are actively injecting and using drugs, because I believe that they are key. They're key actors in this plan for HCV elimination. Just recently, this year, January, there was a paper published by Van Santen and colleagues that they emulated a clinical trial of HCV prevention using some observational data from Melbourne, Vancouver, and Amsterdam. And what they showed was that high levels of engagement and harm reduction, meaning active injectors who are on medication for opioid use disorder and who are also acquiring their syringes and other equipment from a syringe service program, that participation reduced their incidence of HCV infection by 74%. Now, that's a very high level of harm reduction engagement that may be difficult to achieve in a lot of US settings. But I think it's important that we emphasize that we can prevent HCV infection in people who use drugs, and that should be part of an overall plan for HCV elimination. So in addition to reducing hepatitis C virus-related mortality and also improving health and quality of life for individual patients, a lot of the benefit of treatment will come in the form of eradicating infection in active injectors who will at that point be no longer at risk for transmitting HCV to others. Also, most of the new infections in the US are in young PWID who have the lowest rates of engagement in substance use disorder treatment and hepatitis C virus treatment. The nearly 4 million people who inject drugs in the United States that Dr. Martin mentioned, they're significantly younger than prior cohorts of people who inject drugs. So this is there's a very strong rationale, I believe at this point, for focusing eradication efforts on young and active people who inject drugs. I see nodding. I feel like every one of the speakers agrees with this so far. So I want to ask a question of Dr. Martin. More than 10 years ago, some of the modeling studies that you and others were involved in, they predicted elimination of HCV a couple of decades with what was termed achievable scale-up of treatment with the direct-acting antivirals. I think that, so I want to ask you, based on your work and others, it seems that modeling, first of all, should focus on the local level, and that it should be discussed and framed. The results of modeling that show that this level of treatment will contribute to HCV elimination should be framed in relation to what is feasible and achievable in terms of treatment access. So how would you go about estimating what is an achievable level of treatment for people who inject drugs? Thank you.
Thanks, Holly. That's a great question. And I'll answer it in two parts. So the first part, I'll answer your second question first, or the end of your question first, in terms of how do we determine what is achievable? And you're absolutely right that the modeling is clear that these epidemics are local, and that strategies, there will not be a one-size-fits-all strategy. You need to know and understand your local epidemic in order to understand what is required to achieve elimination. We see a lot of heterogeneity across the settings that we've modeled, and they require different levels of treatment, levels of harm reduction, scale-up, et cetera. So the point that I would make then associated with that is that in order to understand what is needed locally and inform those modeling estimations, we need good local data. We need local surveillance data. We are fortunate to have relied in many cases on research studies like the studies I mentioned today, funded by NIDA, et cetera, that have given us a deep understanding of the local hepatitis C epidemiology that is not always available. So thinking about how we can support particularly rural areas in developing and enhancing their surveillance strategies to help understand their epidemics, as well as monitor their epidemics and their progress towards elimination moving forward, is critical. In 2021, the World Health Organization issued this interim guidance for validation of viral hepatitis elimination, which has a lot of great information in it in terms of alternative metrics that can be used to monitor elimination and different strategies for monitoring, which I think can be helpful for reference. And help us think more critically about how we're actually doing the monitoring. The part of your question about achievability, I think, is really important. And I'd like to say that we did feel that the treatment rates that we were simulating many years ago were achievable. And we're starting to have real world evidence now in places like in Australia, where we've seen among people who inject drugs, there has been a substantial scale up in hepatitis C treatment. And then their ongoing national surveillance among people who inject drugs has shown steady declines in terms of chronic prevalence over time and reductions in new infections. And so we're starting to see this real world evidence that not only can these treatments, scale up levels that we thought were achievable be achieved in some settings, but actually reduce transmission and reduce incidence. So it will differ, but I do still believe that this is an effort that is achievable if we have the data and the support to scale up.
Thank you, Natasha. Can I ask my other two questions? Yes, I think, John, you're muted, so I can't tell if you're saying yes.
Yes, let's go around and get everybody involved in the conversation first, if that's okay, Holly. I wanted to turn it over to Carolyn just to get her remarks in general, but I know Carolyn's particularly interested in improving the quality of surveillance for hepatitis. in the country. So you might want to touch on that, Carolyn, among other perspectives that you have. I'll turn it over to you.
Oh, great. Thank you. I just echo my thanks to all of you who organized and for the terrific work that was presented. Really sensational. So, John, I think just to address your question really quickly, but I want to get back
Sure.
to some other things. But yes, exciting. Surveillance is being expanded. Prior to 21, only 14 jurisdictions were being provided surveillance funding, because of limitation of resources. And in 2021, we issued a new funding opportunity for state and local health departments, and tremendous appetite for this. 59 jurisdictions, all that applied were funded, and that basically to get national coverage. Of course, with the resources remaining the same, that means the amount of money that actually goes out the door per jurisdiction is small, but it is remarkable what these jurisdictions are doing with 2 or 3 FTEs that they receive. And we've seen that. We've seen case definitions be updated and the consumption and utilization of data increase. Obviously, in order to span the hepatitis and also the acute as well as chronic is going to take even more resources. But I wanted to come back as well to just, there are about a dozen countries on track to eliminate viral Hep C, and we're not one of them. We know the recipe. Natasha alluded to it. There's great data out of the PIVOT study that just came out of Australia. We can increase treatment rates to more than 90%, reduce time from testing to treatment, and increase SVR rates to meet our targets and meet our goals. But it's going to take advanced diagnostics, unfettered access to treatment, and the implementation that has been reinforced in what we've seen in these presentations through the modeling, through the decentralized, simplified, integrated services where people who use Inject drug actually receive care, including peer support. So thank you for your remarkable work. Obviously, we need to, with the current resources, maximize and scale up these kind of highlight projects so that we continue to fill in the patchwork, but also hopefully, as we get those right-sized resources, and I'm just going to remain optimistic. Obviously there's a proposal for a national hepatitis C elimination initiative, which many of you are not only well aware of, but involved in. And, those pillars, the point of care diagnostics, the unfettered access to treatment, and the comprehensive public health implementation in those high impact settings where people receive services, including corrections, SSPs, substance use disorder treatment centers, and then the other safety net centers that public health departments work in every day. So I think I don't have any questions. I just want to thank you. Like Natasha, the modeling is also, whether it's the study where we've got to get to the top right of the quadrant for both MAT and substance SSPs. We will not treat our way out of this exclusively. The incidence rates have shown us that, but that's why it's so nice to see, addiction medicine, SAMHSA, molecular surveillance, and Hep C treaters all coming together to talk about this, because that's what it's going to take. So thank you. That's all I have.
Thank you. Yeah, and this collaborative effort across agencies that's represented by the projects we're highlighting today. And I'm fully endorse Natasha's view that what we have as goals for the U.S. are feasible because they've been close to being achieved elsewhere. So we have to be aspirational and not just reasonable sometimes. Let me turn it over to Eyasu. Eyasu's been working on a variety of projects, specifically, and some of the ones that have been touched on here today. So I also want to give you a moment or two to have a perspective, and if you have a question, please share it.
Thank you very much to the organizers and the presenters on this important topic and challenging area as we work to eliminate viral hepatitis as a public health threat. I want to put a couple of data points that probably support the discussions that we have had thus far and conclude quickly. So unlike other hepatitis, acute hepatitis C cases continue to increase dramatically with an estimated 70,000 acute hepatitis C cases in 2021 alone, primarily among reproductive aged individuals and in association with injection drug use. With more than half of acute cases resulting in chronic infection, it's not surprising that we're now seeing multiple generations affected by chronic hepatitis C. Further decreases in hepatitis C-related mortality, which began to decline after the release of the second generation DAS in late 2013, have also kind of stalled. And updated prevalence estimates indicate that national prevalence of hepatitis C has remained relatively unchanged throughout the DAA era. The unchanged hepatitis C prevalence is particularly striking given that an estimated 1.2 million people received curative treatment with DAS during 2014 to 2020. This is because new infections continue to rise, and while diagnosis is increasing in 2019 and 2020, only 1 in 3 people with diagnosed infection and health insurance had received timely treatment, setting the stage for disease progression and ongoing transmission. Notably, treatment rates were even lower, like 1 in 4 among Medicaid recipients and young adults. And this analysis didn't even account for uninsured persons who experience additional barriers to diagnosis and treatment. It is clear that in order to meet our national elimination goals, we must increase access to prevention, diagnosis, and treatment services through innovative models of care that meet clients with and at risk for viral hepatitis in setting where they receive care. Thank you. I don't have a question for now.
Thank you, Eyasu. Let me go over to Yngvild Olsen now for some comments from the SAMHSA perspective. Yngvild?
Oh, and my apologies. Hopefully everyone can hear me. I am in a hallway in at a conference that the doors just opened.
So far, so good.
But it's just so thrilled to be able. Yeah, great. Just thrilled to really be able to participate in this incredible panel and discussion, and following these incredible presentations. This is hepatitis C elimination and the integration of hepatitis C and substance use disorder services, focusing on people who inject drugs. Only as a physician, having treated people with hepatitis rewards that can have, but also to SAMHSA, and being part of this work is a priority for SAMHSA as part of really looking at integrated care. SAMHSA, it was so thrilling to also hear Dr. Cordes talk about the state opioid response program. SAMHSA has a number of grant programs that support and increasingly support the integration of hepatitis C services, particularly diagnosis and then linkages to care across not only the state opioid response program, but also a number of our the Minority AIDS Initiative that also then incorporates hepatitis C, as well as other programs and grant programs that I think as we can envision, and as people are seeing the benefits of really curative treatments that are not the old interferon and hard to tolerate regimens, that really that reality and the vision of being able to cure hepatitis C and reach elimination is something that is increasingly being recognized among the behavioral health world as well. And I so appreciated the focus on peers, and peers as a critical part of the multidisciplinary team, because making sure that this isn't a kind of a there's not one entity, there's not one and reach people kind of where they are, but that coordination between harm reduction, treatment, and hepatitis the epidemiologist, it's really what's going to get us there. So just really thrilled to be able to be part of this. I had I think a couple of questions as well for our panel, our presenters, and perhaps just one to, we've been talking about hepatitis C outcomes, which is incredibly important. The other piece that, there has been some research out of an urban center where they've also used peer navigators for hepatitis C who have lived experience with hepatitis C to help engage individuals who also use substances. And they've, as a secondary outcome, also saw reductions in substance use. And that for people, on the behavioral health end and the behavioral health providers as a benefit and a reason to really help integrate these services into their treatment modalities, may be another link and a way to really get that. And so I wondered in your work, and maybe for all of you, if that's also something that you are looking at or seeing, even if it's just on a qualitative basis. I don't know if you can still hear me. Yeah, but maybe Dr. Cordes, just curious if that's something that you, reductions in substance use, even if it's not engagement into something that you all.
Yeah, absolutely. I think this is crucial, and thank you so much for raising this issue. I think it's really a both and for scaling up harm reduction and integration with substance use disorder treatment. I think we're in this window that until we can get the community viral load of hepatitis C below some threshold that Dr. Martin and others have suggested, we're really going to need all of it on an ongoing basis. So in the Oregon Hope study, we are very keen to analyze the data we've been collecting around self-reported substance use, as well as treatment engagement, and that'll be forthcoming.
Thank you. Yngvild, while you're on, I was interested in you could be specific about what are the options for SAMHSA to support hepatitis C testing and treatment in SAMHSA supported treatment centers and improve the quality, timeliness, completeness of data coming from those centers regarding the number of persons being tested and treated for hepatitis C.
Yeah, no, thanks for that question. So the SAMHSA programs that, as I mentioned, the State Opioid Response Program, there's also the Minority AIDS Initiative. We have a program called MAP-PDOA, which essentially is a medication access program, medications for opioid use disorder. We have incorporated hepatitis C testing and vaccination for hepatitis B and A in also in the Recovery Community Support Network grant program, the Building Communities of Recovery grant program. So there's a very long list that the folks can find on our website. Notices of funding opportunities that are out currently. And one of the pieces that within the the kind of authorities that SAMHSA has is we can support testing and linkage to care. Unfortunately, SAMHSA's funds cannot be used to support the treatment piece. And so that's, I think for us, really those partnerships and making sure that, that as we are advancing this from SAMHSA's end, really making sure that we have the partnerships, not only with CDC and NIDA, but also with then our grantees on the ground. And that's something that so that we can get people from test to treat.
Thank you. No, go ahead, please.
No, I was just going to say that in terms of data collection, so there are data elements related to the testing piece that then data SAMHSA collects as a result of those grantees and those grant awards.
Yeah, really be great to see how we can make those as available as possible. And those activities you pointed out in those different initiatives for hepatitis test and treat, are those optional for people to apply to, or are those mandated to as a requirement for federal funding?
So it depends a little bit on the program. In some, they are required, and others they are kind of optional, allowable.
Yeah. Holly, you might have another question, please.
I do. Thank you, John. So I have a question for Todd Allen. You know, I love the idea of implementing GHOST as a surveillance mechanism to monitor progress toward elimination, but also lead to rapid response in the event of clusters or outbreaks. So this, maybe Carolyn could weigh in on this question too, but what do you think about implementing like sentinel GHOST surveillance in subgroups, for example, of young active injectors in different settings?
Yeah, I can go first. No, I think it's a great idea, Holly. I think you know, if you can get more density within a particular area, number one, you're going to find out a lot more, or I think we're just scraping the surface to really understand what's going on in these particular communities that we've started in. I think the downside, however, is that you know, you may not identify clusters. So again, if you can make two assumptions, one is that there are clusters out there to be found, and if so, we can make a bigger intervention with bigger bang for your buck, if you will. On the other hand, you could assume maybe the clusters are not always frequent, in which case you might put a lot of effort into one particular area and not necessarily understand any more than you did before. So something we need to just understand a little bit more of the frequency of clusters. The only way to do that is to gain deeper data or coverage in a couple particular areas, in particular rural areas, to understand, you know, just how often do we see these types of clusters or Scott County type situations. Maybe Carolyn has more to add.
No, thank you so much. I think I would add that, you know, we clearly see the utility of it in describing and untangling and really characterizing known identified clusters. Then as we move the question, Todd and his group have done a wonderful job with all of the recipients of this to show the feasibility of moving it into other areas, but he also highlights things that would be needed, you know, a massive increase in the coverage of it, also simplified collection techniques. And so I think before we really can answer whether it has the utility to provide early detection of clusters and early interruption of clusters, we need some more data. So I know our epi surveillance branch is working with our laboratory branch and just put out a funding announcement and are about to announce awards to have 2 jurisdictions actually really integrate epi surveillance data with molecular surveillance data in their jurisdiction and ask specifically those 2 questions. And you know, then, and as Todd mentioned too, there's, in addition to answering these questions, if those are to be favorable and the utility is there, then there are other questions too in terms of implementing. You know, how do you implement? What are the client considerations? We're still working in a number of states where viral hepatitis is criminalized. So how to use it in, you know, to add value without unintended consequences too. Over. I don't know, Eyasu, if you have anything you want to add.
No, thank you. I think that's it.
I'll turn it over to Natasha just for a moment. Natasha, is that kind of data coming out of that, you know, goes showing the types of networks, et cetera? Is that the kind of data that would inform modeling, at least at the local level or at the national level? How would you respond to that, please?
It's a great question, and I can say that we actually have an NIH grant right now with that I'm co-PI with a colleague of mine, Susan Little. And it's actually an HIV grant that's a partnership with Miami-Dade County, where we're building transmission models that are directly integrating both the epidemiological data as well as the molecular transmission network data to inform the modeling estimates and understandings both of incidence, but also incidence between groups and geographical locations. And that this is really innovative work trying to understand what are the features of the networks that are important, and also how do we, for example, account for the fact that there's, only a portion of individuals are getting sequenced and we're not seeing the complete network. How do we, account for that bias? So that's ongoing work that we're doing in HIV, but our preliminary analyses indicate that they do help us understand the incidence flows between groups and use the modeling to better direct prevention resource allocation. So, I think, I can't say for sure that a similar approach could be taken for hepatitis C, but of course it does require, it would require more sampling, particularly in local areas, to do it at a local level.
Be interesting to take a look at that.